Welcome to the Eye Experts. I'm Dr. Eli Sluch, and today I'll be showing you a pterygium of an autograft. So I start off with marking the pterygium on each side, and then I mark it about 2 millimeters posterior. I like to have a nice fat mark because what I'm going to do is I'm going to transect it kind of halfway, so I still remember where my borders are. This will be important down the road when I'm actually going to be suturing the graft and orienting the graft because that conj is kind of hard to see. So here I cut it down on each side of the bare sclera, put the scissors down all the way to make sure that the tunnel is complete, and then transect the pterygium. Here I do my subtenons block with some lidocaine. I've started just making the subtenons block through the pterygium incision instead of making a separate one just because you already have a big hole. Why make another one? So here I have my pterygium. I peel it off, just kind of take the bulk off, and then afterwards I'm going to take a 57 blade. I'm just going to kind of find the epithelium border and start scraping at it less than 90 degrees. This way, if there's any Salzmann's notches like there was in this case, I'll be able to peel it off at the same time. So we have a really nice clear corneal bed now, and it looks good. So now I'm just gonna go and see if there's any tenons tissues. I like to excise extra tenons on each side, just because that's gonna cause contraction later, and I really want my graft that I'm gonna put there to have the best chance of attaching and not dying. So now that we have the tenons removed, we're gonna get some um, basically some cautery and some MMC. So here's my cautery unit. So what I want to do is I want to burn off the blood vessels that are bleeding, but I do not want to have a white scleral bed. The reason for that is my graft is going to need a vascular supply. If I burn off all the blood vessels, it's not going to have a blood. It's not going to have a vascular supply. So here I just cut cutters a little bit. I'm putting my mitomycin sponge. This is a 0.4 milligram per milliliter mitomycin. And I usually just keep it there for about a minute. So what I do is, again, I get the sponge. You can use a wick for it. And I put it over the defect and I want to cover it kind of the conch because that conch I'm holding over it, that's actually where the pterygium is going to grow. So I want that area to absorb as much mitomycin as possible. Because we know for pterygium, we want to cover the defect, we want to add mitomycin, and sometimes add some limbal stem cells. Those are basically the three things we can do to keep it from recurring. If we leave it as a bare sclera, if the graft falls off later, it's going to become a bare scleral pterygium. So, all those reasons I like to use mitomycin on all of my pterygiums. Now, it's important to really irrigate the scleral bed afterwards. So here I have my BSS. I irrigate about 30 cc's of BSS. I really want to open up that conjunctival pocket and really, really irrigate all that mitomycin out. Because I really think that if we don't get all the mitomycin out, it's going to cause scleronechosis later. So here I'm going back to the cautery, and this is when I'm actually kind of trying to get fairly good hemostasis. And again, I'm only getting the ones that are bleeding. I still want blood vessels over there. So now we got the pterygium removed and the scleral bed nicely cleaned up. It's time to measure it and harvest our autograft. So I have calipers, and I'm using calipers to measure. And I'm going to take the graft superiorly. So what I'm going to do is I'm going to dry the area because I'm going to mark it again. Take my calipers right there. That's 8 millimeters. So we're going to mark 8 millimeters. And then what I like to do is I like to take the marker and I really like to make a really big fat limbal mark right on that conch. And the reason for that is once the graft is harvested, I want to make sure the orientation is correct. And the easiest way to do that is to have a nice fat mark. So now I'm going to take my rest of my subtenons and I'm going to inject as a subconjunctival incision. There's already a hole there. And this is really going to elevate the conch. Now, why elevate the conch? Because what's getting hydrated over there is the tenons. So that tenons layer that was super thin is now super thick. So what I want to harvest for my graft is just the conjunctiva. I want to have as little tenons for it as possible. So if I took my tenons layer and now it's 10 times thicker, when I cut it, I know I'm not cutting all the way down. So I'm actually going to be harvesting much less tenons than I would if I didn't do the hydration of the tenons. So here I take my Westcott scissors and I just cut the conch. All I'm doing, I'm just doing little nips on the conch. on each side, just like I'm doing a tunnel. And then what I'm going to do is I'm going to take my scissors and I'm going to pass it right under the conch to again create a tunnel. So here we are, I'm kind of holding it, trying to not rip into the conch. The conch is pretty soft. So here I'm just slowly going through, opening them up, opening them up, opening them up, and that's going to go all the way through. So there we go. Now I'm all the way through. I'm going to cut the conch superiorly as far back as I can go. I like big grafts. So there we go. This is as big of a graft as I can get, and there I'm harvesting. If you see, again, because it has such a fat mark, the conch is stained. So I know exactly where the conch is and where the tenons are. So here I'm just, again, small little nips, and I'm just really cutting all the tenons back. I want to have as little tenons as possible without perforating the graft. It's okay to perforate a little bit, but again, as long as you have one piece, it's much easier to work with. The reason why you don't want tenons is because tenons will contract. So if I can harvest a conjunctival graft with minimum tenons, when I lay it down, it's going to stay like that. It's going to vascularize well. It's really going to help the pterygium. If I leave a lot of tenons on, I'm going to put it down, it's going to contract. It may not take as well, it may slough off. So again, we want to really release the tenons. So here, I gotta release the tenons. I'm going to go limbally. I kind of hug the limbus and I cut that graft. So now I'm going to flatten out my graft, get it oriented. So again, I want to make sure it's the correct side. And again, see, it's very nicely stained. I'm going to lift the corner in a minute just to show that the other side is clearly not stained. See, now, the thick blue stripe is the limbus, so I'm going to orient it along the limbus. So I'm going to dry the graft. I like to use glue and suture, and the glue works well when the bed is dry. The glue does not work well when the bed is wet. So here I'm going to drag the graft right there. There it is. And what I do first is once I have it oriented, I'm going to take some 10 nylon and I'm going to secure it on on each of the corners. And when I do these passes, I really do try to get a little piece of sclerosum cornea because I really do not want the graft to move, and that's going to provide the most tensile strength, basically. Because we know we do not want the graft to move from those two corners. So I'm going to suture one side, and then I'm going to suture the other. Now, people would ask why glue it and suture it, and that's because I'm afraid that one method will be insufficient. I've had cases where I just glued the graft and the pterygium sloughed off, and I've had cases where I suture a pterygium, but it doesn't lay as flat. You will see when you glue that you can really nicely roll the pterygium evenly. You will see how thin it is. You can see how nicely it attaches to the eye. I just don't think that's really possible with just suture. That's why I like the combination of both. But I just don't trust the glue. That's why I want to put some sutures in. So here I sutured the two corners. What I'm going to do now, I'm going to flip the graft over. So I'm going to take the temporal part of the graft, grab it, and rotate it back over the cornea. Once that happens, I'm going to nicely dry the bed. So here we go. I have it rotated while I'm waiting for my glue. And I'm going to take some Wixel sponges and I really am going to dry that. I'm going to just the graft. You gotta be careful because the graft does kind of get sticky to the wick, but see, much drier. And I'm going to get all that ooze out. I want to get that blood clot out. I again want to make sure that the scleral bed is really dry because the glue just won't work. So if there's any bleeding at this point, I will also go and cauterize them again. Like right now, there was a little piece of pterygium left over. You see when I cut it started bleeding a little bit. So what I'm going to do, I'm going to take the cautery back and I'm going to burn that a little bit because it's just not going to attach. And if you leave blood at the pterygium scleral interface, it's inflammatory. It probably will not attach as well. Blood, it's just not going to heal very well. So that's pretty dry. So what I'm going to do now is I'm going to get my thick and thin. I always check. So see how that's viscous. So that's thick. And then I'm going to take my thin glue right there. That's thin. You just want a very minimal amount because it's just like super glue. You just don't want too much. So here I flip my graft over, and here I'm using the steamroll technique with bent McPherson's, and I'm just really stretching it out along the sclera. It's gonna look really nice. It's flattened out really well. We have very little tenons in that graft. That looks great. So what we're gonna do now is I'm still gonna take my 10 nylon and I'm gonna suture the other two corners. Now, some people ask why not use Vicryl. I've used Vicryl before. I don't like how inflammatory it is. I've noticed that I used to do these sutures of Vicryl. It's like, well, they're going to absorb. But by 2 weeks, the patient comes in, their eye is red right around the Vicryl. It hurts, it's irritating. And the whole point of treating the pterygium is the inflammatory irritation. So I'm really concerned that Vicryl actually causes the pterygiums to recur more frequently just because of the extra inflammation they cause. So I just stop. I've noticed that cutting out Vicryl, if I'm cutting out Vicryl, I'm just not going to put any Vicryl. So I like to use nylon, and then later in clinic, I just take it out with probably like a 27 gauge needle. It cuts really well. I don't usually do more than two, just because I used to do a very temporal suture, but then I've realized that that suture doesn't usually hold. It would break for me like 80% of the time. Just that lip right there temporarily, it just does not like to do it. So sometimes I will actually suture the graft down to the sclera over there, but if I have glue, I don't really need to. So if you don't have glue, I'd recommend doing just a partial scleral pass just temporarily just to make sure it stays flat. And that's it. The pterygium looks great. Right before I get out, I take my scissors and I do a fornix check to make sure no glue is in there. Because if you get too much glue, it's going to stick over there and it's going to rip the pterygium out. So right there, just break that, make sure it's nice and clean. No adhesions to the speculum.